Good afternoon. Today I would like to introduce you the last pharmacology lecture, Antimicrobial Drugs. Lecture plan. First, general considerations of antimicrobial agents. Second, sulfonamides, cotrimoxazole and quinolones. Third, beta-lactam antibiotics. And fourth, other antimicrobial drugs. Let's start from general considerations of antimicrobial agents. Classification of antimicrobial drugs is based on A. Chemical structure, B. Mechanism of action, C. Type of organisms against which primary active, D. Spectrum of activity, E. Type of antimicrobial action, and F. Origin of antibiotics. The first classification is based on chemical structure. First group, beta-lactam antibiotics. Second, sulfonamides and related drugs. Third, diaminopyrimidines. Fourth, quinolones. Fifth, tetracyclines. Sixth, nitrobenzene derivative. Seventh, aminoglycosides. Eighth, macrolide antibiotics. Ninth, lincosamide antibiotics. 10th, glycopeptide antibiotics. 11th, oxazolidinone. 12th, polypeptide antibiotics. 13, nitrofuran derivatives. 14, nitroimidazoles. 15, nicotinic acid derivatives. 16, polyene antibiotics. 17, azole derivatives. And 18th, others. Classification based on mechanism of action. First, inhibit cell wall synthesis. Second, cause leakage from cell membranes. Third, inhibit protein synthesis. Fourth, cause misreading of mRNA code and affect permeability. Fifth, inhibit DNA gyrase. Sixth, interfere with DNA function. Seventh, interfere with DNA synthesis. And eighth, interfere with intermediary metabolism. And in here you can see schematic representation of main mechanisms of antibiotic action mentioned before. On this and next 5 slides you will see different pictures. You can pause them and take a look later. In here you can see peptidoglycan structure. In here structure of repeating disaccharide. In here transglycosylation and transpeptidation. In here, cell wall in gram-positive and gram-negative bacterium. And in here, one more slide about gram-positive and gram-negative bacterium. The main difference between gram-positive and gram-negative bacterium is that gram-negative ones has got outer membrane, lipopolysaccharide and protein. Third classification, type of organisms against which primary active. First, antibacterial. Second, antifungal. Third, antiviral. Fourth, antiprotozoal. And fifth, antihelmintic. In brackets you can see an examples. Fourth classification, spectrum of activity. Narrow spectrum and broad spectrum. The initial distinction between narrow and broad spectrum antibiotics is no longer clear-cut, sharply defined. Drugs with all ranges of intermediate bandwidth, for example extended spectrum penicillins, neurocephalosporins, aminoglycosides, fluoroquinolones are now available. However, the term narrow spectrum and broad spectrum are still applied. In here you can see standard microbes which are used for antibiotic activity determination. For example, Bacillus subtilis, Bacillus cereus, Escherichia coli, Pseudomonas aeruginosa, Staphylococcus aureus, and Candida albicans. Classification E, type of action. Primarily bacteriostatic, for example, sulfonamides, tetracyclines, chloramphenicol, erythromycin, clindamycin, linezolid, etambutol. Primary bactericidal, penicillins, cephalosporins, aminoglycosides, vancomycin, polypeptides, ciprofloxacin, rifampin, isoniazide, pyrazinamide, metronidazole, cotrimoxazole. Some primary static drugs may become cidal at higher concentrations, as attained in the urinary tract, for example, erythromycin, nitrofurantoin. On the other hand, some cidal drugs, for example cotrimoxazole, streptomycin, may only be static under certain circumstances. Classification F. Antibiotics are obtained from fungi, penicillin, cephalosporin, grisofulvin, bacteria, polymyxin B, tyrothricin, colistin, aztreonam, bacitracin, and actinomycetes, aminoglycosides, macrolides, tetracyclines, chloramphenicol, etc. Problems that arise with the use of antimicrobial agents. First, toxicity. It can be divided into local irritancy. This is exerted at the site of administration. All antimicrobial agents, especially erythromycin, tetracyclines, certain cephalosporins, and chloramphenicol, are irritants. Other is systemic toxicity. Almost all antimicrobial agents produce dose-related and predictable organ toxicities. Some have high therapeutic index, for example penicillins, cephalosporins, erythromycin. Others have low therapeutic index, for example aminoglycosides can cause 8th cranial nerve and kidney toxicity, tetracyclines, liver, kidney, anti-anabolic effect, chloramphenicol, bone marrow depression. Still others have a very low therapeutic index. Use is highly restricted to conditions where no suitable alternative is available. For example, polymyxin B can cause neurological and renal toxicity, vancomycin, hearing loss, kidney damage, amphotericin B, kidney damage, bone marrow, and neurotoxicity. In cases of renal failure and liver diseases, the dose must be reduced. In here you can see an examples of reduction of dose in cases of renal failure and in cases of liver disease. In some cases of these pathologies, some drugs must be totally avoided. The next problem which arises with the use of antimicrobial agents is hypersensitivity reactions. Practically all antimicrobial agents are capable of causing hypersensitivity reactions. The whole range of reactions from rashes to anaphylactic shock can be pronounced, which are unpredictable and unrelated to dose. More commonly, hypersensitivity reactions occur in use of penicillins, cephalosporins, sulfonamides, fluoroquinolones. The third problem is drug resistance. First type, it can be natural resistance. Some microbes have always been resistant to certain antimicrobial agents. They lack the metabolic process or the target site which is affected by the particular drug. This is generally a group or species characteristic. Gram-negative bacilli are normally unaffected by penicillin G. Aerobic organisms are not affected by metronidazole. Anaerobic bacteria are not inhibited by aminoglycosides. Mycobacterium tuberculosis is insensitive to tetracyclines. Next type is acquired resistance. It is the development of resistance by an organism which was sensitive before due to the use of an antimicrobial agent over a period of time. This can happen with any microbe and is a major clinical problem. However, development of resistance is dependent on the microorganism as well as on the drug. Some bacteria are notorious for rapid acquisition of resistance, for example Staphylococci, coliforms, tubercle bacilli. Others have not developed significant resistance to penicillin despite its widespread use for more than 50 years. Gonococci quickly developed resistance to sulfonamides, but only slowly and low-grade resistance to penicillin. However, in the past 40 years, highly penicillin-resistant gonococci producing penicillinase have appeared. Drug resistance may be developed by mutation or gene transfer. First is mutation. It is a stable and heritable genetic change that occurs spontaneously and randomly among microorganisms. Any sensitive population of a microbe contains a few mutant cells which require higher concentration of the antimicrobial agent. Thus, in time it would appear that a sensitive strain has been replaced by a resistant one. This is called vertical transfer of resistance, is relatively slow and usually of lower grade. Single-step mutation. A single gene mutation may confer high degree of resistance, emerges rapidly. And multi-step. A number of gene modifications are involved. Sensitivity decreases gradually in a stepwise manner. Sometimes mutation acquisition of resistance is accompanied by decrease in virulence. The next is gene transfer. Gene transfer, infectious resistance. The resistance-causing gene is passed from one organism to the other, called horizontal transfer of resistance. Rapid spread of resistance can occur by this mechanism, and high-level resistance to several antibiotics, multi-drug resistance, can be acquired concurrently. The resistance is caused by microbial, mutation, destruction, efflux, genetic transfer, conjunction, transformation, transduction. Prevention of drug resistance. No indiscriminate and inadequate or unduly prolonged use of antimicrobial agents should be made. This would minimize the selection pressure, and resistant strains will get less chance to preferentially propagate. Prefer rapidly acting and selective narrow-spectrum antimicrobial agents whenever possible. Broad-spectrum drugs should be used only when a specific one cannot be determined or is not suitable. Use combination of antimicrobial agents whenever prolonged therapy is undertaken. Infections by organisms, notorious for developing resistance, must be treated intensively. The fourth problem which arises with the use of antimicrobial agents is superinfection or suprainfection, appearance of a new infection as the result of antimicrobial therapy. Use of most antimicrobial agents cause some alteration in the normal microbial flora of the body. The normal flora contributes to host defense by elaborating substances called bacteriocins, which inhibit pathogenic organisms. Further, ordinarily, the pathogen has to compete with the normal flora for nutrients, etc., to establish itself. Lack of competition may allow even a normally non-pathogenic component of flora, which is not inhibited by the drug, to predominate and invade, for example, Candida. More complete the suppression of body flora, greater are the chances of developing superinfection. Thus, it is commonly associated with the use of broad, extended-spectrum antibiotics, tetracyclines, chloramphenicol, ampicillin, cephalosporins, especially when combinations of these are employed. Superinfections are more common when host defense is compromised. Conditions predisposing to superinfections. Corticosteroid therapy, leukemias and other malignancies, especially when treated with anti-cancer drugs. These drugs are also immunosuppressant and decrease white blood cells count. Acquired immunodeficiency syndrome, AIDS, agranulocytosis, diabetes, disseminated lupus erythematosus. Fifth problem is nutritional deficiencies. Some of the B-complex group of vitamins and vitamin K synthesized by the intestinal flora is utilized by man. Prolonged use of antimicrobials which alter this flora may result in vitamin deficiencies. Neomycin causes morphological abnormalities in the intestinal mucosa, steatorrhea and malabsorption syndrome can occur. 6 is masking of an infection. A short course of an antimicrobial agent may be sufficient to treat one infection, but only briefly suppress another one contacted concurrently. The other infection will be masked initially, only to manifest later in a severe form. Syphilis masked by the use of a single dose of penicillin, which is sufficient to cure gonorrhea. Tuberculosis masked by a short course of streptomycin given for trivial respiratory infection. Choice of antimicrobial agents. The choice depends on the particulars of the patient, the infecting organism, and the drug. Patient factors: age, renal and hepatic function, local factors, drug allergy, impaired host defense, pregnancy, genetic factors. Organism-related considerations. Clinical diagnosis itself directs choice of the antimicrobial agent. A good guess can be made from the clinical features and local experience about the type of organism and its sensitivity. Choice to be based on bacteriological examination. and drug factors, spectrum of activity, type of activity, sensitivity to the organism, relative toxicity, pharmacokinetic profile, route of administration, evidence of clinical efficacy, and cost. In here, I would like to stop on one of the organism-related considerations, which is choice based on bacteriological examination. This may not be always possible. For example, bacteriological services are not available. Bacteriological services are available, but treatment cannot be delayed. Bacteriological services are available, and treatment can be delayed for a few days. Bacteriological sensitivity testing, generally done by disc agar diffusion method, using standardized concentration of antibiotics based on clinically attained plasma concentrations of these. Bacteriological examination shows minimum inhibitory concentration, MIC, the lowest concentration of an antibiotic which prevents visible growth of a bacterium after 24-hour incubation in microwell culture plates using serial dilutions of the antibiotic is more informative. Minimum bactericidal concentration, MBC, is determined by subculturing from tubes with no visible growth. If the organism is killed, no growth will occur, but if it was only inhibited in the parent culture, it will grow on subculturing in antibiotic-free medium. And post-antibiotic effect, PAE. After a brief exposure, if the organism is placed in antibiotic-free medium, it starts multiplying again, but after a lag period, which depends on the antibiotic as well as the organism. Time required for reattainment of logarithmic growth. And in here I would like to stop on combined use of antimicrobials. First, to achieve synergism. Second, to reduce severity or incidence of adverse effects. Third, to prevent emergence of resistance. Fourth, to broaden the spectrum of antimicrobial action. This is needed in treatment of mixed infection, initial treatment of severe infections, and topically. Disadvantage of antimicrobial combinations. First, they foster a casual rather than rational outlook in the diagnosis of infections and choice of antimicrobial agent. Second, increased incidence and variety of adverse effects. Toxicity of one agent may be enhanced by another. For example, vancomycin plus tobramycin and gentamicin plus cephalosporin produce exaggerated kidney failure. Third, increased chances of superinfections. Fourth, if inadequate doses of non-synergistic drugs are used, emergence of resistance may be promoted. And fifth, higher cost of therapy. Prophylactic use of antimicrobials. First, prophylaxis against specific organisms. Second, prevention of infection in high-risk situations. And third, prevention of infection in general. And the last slide, failure of antimicrobial therapy. First, improper selection of drug, dose, route or duration of treatment. Second, treatment begun too late. Third, failure to take necessary adjuvant measures. Fourth, poor host defense, as in leukemias, neutropenia, and other causes, especially if a bacteriostatic antimicrobial agent is used. Fifth, infecting organism present behind barriers, such as vegetation on heart valves, inside the eyeball, blood-brain barrier. Sixth, trying to treat untreatable viral infections or other causes of fever, malignancy, collagen diseases. And seventh, presence of dormant or altered organisms, the persisters, which later give rise to a relapse. The next part of our lecture is sulfonamides, cotrimoxazole, and quinolones. Classification of sulfonamides. First, short-acting, 4-8 hours, sulfadiazine. Second, intermediate-acting, 8 to 12 hours, sulfamethoxazole. Third, long-acting, 7 days, sulfadoxine, sulfamethopirazine. And fourth, special-purpose sulfonamides, sulfacetamide sodium, mafenide, silver sulfadiazine, and sulfasalazine. Additionally, cotrimoxazole, combination of trimethoprim and sulfamethoxazole. Quinolones and fluoroquinolones, we will talk later in more details about them. The examples: nalidixic acid, cynoxacin, norfloxacin, ofloxacin, levofloxacin, moxifloxacin, trovafloxacin. Let's start from sulfonamides. Many bacteria synthesize their own folic acid, of which para-aminobenzoic acid is constituent and is taken up from the medium. Woods and Fields in 1940 proposed the hypothesis that sulfonamides, being structural analogues of para-aminobenzoic acid, PABA, inhibit bacterial folate synthase and folic acid is not formed and a number of essential metabolic reactions suffer. Sulfonamides competitively inhibit the union of para-aminobenzoic acid with pteridine residue to form dihydropteroic acid, which conjugates with glutamic acid to produce dihydrofolic acid. Also, being chemically similar to para-aminobenzoic acid, the sulfonamide may itself get incorporated to form an altered folate, which is metabolically injurious. Human cells also require folic acid, but they utilize preformed folic acid supplied in diet and are unaffected by sulfonamides. And in here you can see the structure and numbering of atoms of folic acid. And in here you can see folic acid reduction and drug action on it. First of all, reduction of folic acid to dihydrofolic acid by folate reductase and dihydrofolic acid to tetrahydrofolic acid. Trimethoprim is a selective inhibitor of folate reductase in gram-negative bacteria and has little effect on the mammalian enzyme. Methotrexate binds more strongly and is used as an anti-cancer drug. And in here you can see the chemical structure of different sulfonamides. And in here separately the information about cotrimoxazole. Cotrimoxazole once again is fixed dose combination of trimethoprim and sulfamethoxazole. Trimethoprim is a diaminopyrimidine related to the antimalarial drug pyrimetamine, which selectively inhibits bacterial dihydrofolate reductase. Sulfamethoxazole is sulfonamide. And in here you can see sequential block in bacterial folate metabolism. Quinolones. Quinolones are synthetic antimicrobials having a quinolone structure that are active primarily against gram-negative bacteria, though the newer fluorinated compounds also inhibit gram-positive ones. First quinolone, nalidixic acid, was introduced in 1960s, usefulness limited to urinary and gastrointestinal tract infections. A breakthrough was achieved in early 1980s by fluorination of the quinolone structure at position 6 and introduction of a piperazine substitution at position 7, resulting in derivatives called fluoroquinolones with high potency, expanded spectrum, slow development of resistance, better tissue penetration, and good tolerability. For example, in here you can see ciprofloxacin, levofloxacin, and trovafloxacin. Mechanism of action of fluoroquinolones. The fluoroquinolones inhibit the enzyme bacterial DNA gyrase, primarily active in gram-negative bacteria, which nicks double-stranded DNA, introduces negative supercoils, and then reseals the nicked ends. This is necessary to prevent excessive positive supercoiling of the strands when they separate to permit replication or transcription. The DNA gyrase consists of two A and two B subunits. The A subunit carries out nicking of DNA, B subunit introduces negative supercoils, and then A subunit reseals the strands. Fluoroquinolones bind to A subunit with high affinity and interfere with its strands cutting and resealing function. In gram-positive bacteria, the major target of fluoroquinolones action is a similar enzyme topoisomerase 4, which nicks and separates daughter DNA strands after DNA replication. Greater affinity for topoisomerase 4 may confer higher potency against gram-positive bacteria. The bactericidal action probably results from digestion of DNA by exonucleases, whose production is signaled by the damaged DNA. In place of DNA gyrase or topoisomerase 4, the mammalian cells possesses an enzyme topoisomerase 2 that also removes positive supercoils, which has very low affinity for fluoroquinolones, hence the low toxicity to host cells. Side effects: gastrointestinal, nausea, vomiting, bad taste, anorexia. Because gut anaerobes are not affected, diarrhea is infrequent. CNS: dizziness, headache, restlessness, anxiety, insomnia, impairment of concentration and dexterity, caution while driving. Tremor and seizures are rare, occur only at high doses or when predisposing factors are present, possibly reflect GABA antagonistic action of fluoroquinolones. Skin hypersensitivity, rash, pruritus, photosensitivity, urticaria, swelling of lips, etc. Serious cutaneous reactions are rare. Tendinitis and tendon rupture. A few cases have occurred. Risk of tendon damage is higher in patients above 60 years of age and in those receiving corticosteroids. The fluoroquinolones should be stopped at the first sign of tendinitis. Uses: urinary tract infections, gonorrhea, chancroid, bacterial gastroenteritis, typhoid, bone, soft tissue, gynecological and wound infections, respiratory infections, tuberculosis, gram-negative septicemias, meningitis, prophylaxis, conjunctivitis. The third part of our lecture is beta-lactam antibiotics. Beta-lactam antibiotics. First of all, penicillins. Penicillin G, benzyl penicillin. Next, semisynthetic penicillins, which are subdivided. Acid-resistant alternative to penicillin G, penicillinase-resistant penicillins, extended-spectrum penicillins, which are also subdivided into aminopenicillins, carboxypenicillins, ureidopenicillins, and separate group beta-lactamase inhibitors. First of all, penicillin G or benzyl penicillin in more details. Sodium penicillin G, crystalline penicillin injections from 0.5 to 5 million units. Next, repository penicillin G injections are insoluble salts of penicillin G, which must be given by deep intramuscular Neuver IV injection. Next, procaine penicillin G injection, 0.5 to 5 million units, 12-24 hourly, and fortified procaine penicillin G injection. And one more benzathine penicillin G, 0.6 to 2.4 million units, every 2-4 weeks. Semisynthetic penicillins. First of all, acid-resistant alternative to penicillin G, phenoxymethylpenicillin, penicillin V. Next, penicillinase-resistant penicillins, methicillin, cloxacillin, decloxacillin. And extended-spectrum penicillins, which are subdivided into aminopenicillins, ampicillin, bacampicillin, amoxicillin, carboxypenicillins, carbenicillin, and ureidopenicillins, piperacillin, meslacillin. And separately, those drugs which act specifically on beta-lactamase, which are called beta-lactamase inhibitors, clavulanic acid, sulbactam, tazobactam. Some of them are used in combinations with penicillins. Next groups shortly, cephalosporins, which are subdivided into first generation, second, third, and fourth. They can be administered orally or parenterally. In here you can see 4 different generations and the examples of drugs which are used parenterally and orally. Next group, monobactams, which is aztreonam. And one more group, carbapenems, imipenem, meropenem, pharopenem, and doripenem. And separately, once again, beta-lactamase inhibitors, for example, clavulanic acid, and the trade name of the drug amoxiclav, or augmentin, or clavocin, or clavunat. It is a combination of penicillin antibiotic with clavulanic acid. Also one more sulbactam sodium, combination of penicillin antibiotic with sulbactam sodium, and one more beta-lactamase inhibitor, which is tazobactam. The fourth part of our lecture is other antimicrobial drugs. In this part of the lecture we will talk about macrolide antibiotics, lincosamide antibacterial antibiotics, glycopeptide antibacterial antibiotics, oxazolidine-dione antibacterial antibiotics, polypeptide antibacterial drugs, urinary antiseptics, tetracyclines and chloramphenicol, broad-spectrum antibiotics, aminoglycoside antibiotics, and separately other groups of antimicrobials, antifungal drugs, antitubercular drugs, antileprotic drugs, antiviral drugs, antimalarial drugs, antiamebic and other antiprotozoal drugs, and antihelmintic drugs. Firstly, macrolide antibiotics in short. First representative is erythromycin. Now we have newer macrolides: roxithromycin, clarithromycin, azithromycin, and spiramycin. Next, lincosamide antibacterial antibiotics. Representatives are clindamycin and lincomycin. Next, glycopeptide antibacterial antibiotics, vancomycin and teicoplanin. Next, oxazolidine-dione antibacterial antibiotics, linezolid, spectinomycin, quinupristin dalfopristin, mupirocin, fusidic acid. Polypeptide antibacterial drugs, polymyxin B, colistin, bacitracin. Urinary antiseptics, nitrofurantoin, metenamine. Urinary analgesics, phenazopyridine. Representatives of broad-spectrum antibiotics are tetracyclines, for example tetracycline, oxytetracycline, and chloramphenicol. Next group in more details is aminoglycoside antibiotics. These are a group of natural and semi-synthetic antibiotics having polybasic amino groups linked glycosidically to two or more amino sugar residues. Unlike penicillin, which was a chance discovery, aminoglycosides are products of deliberate search for drugs effective against gram-negative bacteria. Streptomycin was the first member discovered in 1944 by Waxman and his colleagues. It assumed great importance because it was active against tubercle bacilli. Others were produced later, and now aminoglycosides are a seizable family. All aminoglycosides are produced by soil actinomycetes and have many common properties. Aminoglycoside antibiotics include the first-in-class aminoglycoside streptomycin derived from Streptomyces griseus, the earliest modern agent used against tuberculosis, and an example that lacks the common 2-deoxystreptamine moiety present in many other class members. 2-deoxystreptamine, 2D representation, oxygens, nitrogens with attached hydrogens in red and blue. Other examples include the deoxystreptamine-containing agents kanamycin, tobramycin, gentamycin, and neomycin. Mechanism of action of aminoglycoside antibiotics. Aminoglycosides display concentration-dependent bactericidal activity against most gram-negative aerobic and facultative anaerobic bacilli, but not against gram-negative anaerobes and most gram-positive bacteria. They require only short contact time and are most effective against susceptible bacterial populations that are rapidly multiplying. These activities are attributed to a primary mode of action as protein synthesis inhibitors, though additional mechanisms are implicated for some specific agents, and/or thorough mechanistic descriptions are as yet unavailable. The inhibition of protein synthesis is mediated through aminoglycosides' energy-dependent, sometimes irreversible binding to the cytosolic membrane-associated bacterial ribosome. Specifically, binding impairs translational proofreading, leading to misreading of the RNA message, premature termination, or both, and so to inaccuracy of the translated protein product. The subset of aberrant proteins that are incorporated into the bacterial cell membrane may then lead to changes in its permeability and then to further stimulation of aminoglycoside transport. The amino sugar portion of this class of molecules are implicated in the association of the small molecule with ribosomal structures that lead to the infidelities in translation. Inhibition of ribosomal translocation, movement of the peptidyl tRNA from the A to the P site, has also been suggested. Spectinomycin, a related but distinct chemical structure class, often discussed with aminoglycosides, doesn't induce mRNA misreading and is generally not bactericidal. Finally, a further cell membrane effect also occurs with aminoglycosides. Functional integrity of the bacterial cell membrane can be lost later in time courses of aminoglycoside exposure and transport. Clinical use. The recent emergence of infections due to gram-negative bacterial strains with advanced patterns of antimicrobial resistance has prompted physicians to re-evaluate the use of these antibacterial agents. This revived interest in the use of aminoglycosides has brought back to light the debate on the two major issues related to these compounds, namely the spectrum of antimicrobial susceptibility and toxicity. Current evidence shows that aminoglycosides do retain activity against the majority of gram-negative clinical bacterial isolates in many parts of the world. Still, the relatively frequent occurrence of nephrotoxicity and ototoxicity during aminoglycoside treatment makes physicians reluctant to use these compounds in everyday practice. Recent advances in the understanding of the effect of various dosage schedules of aminoglycosides on toxicity have provided a partial solution to this problem, although more research still needs to be done in order to overcome this problem entirely. Aminoglycosides are in pregnancy category D, that is, there is a positive evidence of human fetal risk based on adverse reactions data from investigational or marketing experience or studies in humans, but potential benefits may warrant use of the drug in pregnant women despite potential risks. Contraindication for specific diseases. Aminoglycosides can exacerbate weakness in patients with myasthenia gravis, and use is therefore avoided in these patients. Aminoglycosides is contraindicated in patients with mitochondrial diseases, as it may result in impaired mtDNA translation, which can lead to hearing loss, cardiac toxicity, and renal toxicity. The first group of other antimicrobial drugs is antifungal drugs. An antifungal medication is used to treat and prevent mycosis such as athlete's foot, candidiasis, serious systemic infections such as cryptococcal meningitis, and others. Such drugs are usually obtained by a doctor's prescription, but a few are available over the counter. Antifungal drugs general classification. Polyenes binds with sterols in the fungal cell. Azoles inhibit lanosterol 14-alpha demethylase enzyme. Allylamines inhibit squalene epoxidase enzyme. And echinocandins inhibit beta-1,3-glucan synthase enzyme. The next group is antitubercular drugs. They are divided into first-line drugs, second-line drugs, fluoroquinolones, and injectable drugs. First-line drugs: isoniazid, rifampicin, pyrazinamide, etambutol, and streptomycin. Second-line drugs: etionamide, protionamide, cycloserine, terazidone, para-aminosalicylic acid, rifabutin, and tiacetazone. Second-line fluoroquinolones: ofloxacin, levofloxacin, and moxifloxacin. Second-line injectable: kanamycin, amikacin, and capreomycin. And on this slide you can see alternative grouping of antitubercular drugs. There are 5 groups. Group 1, first-line oral antitubercular drugs. Second group, injectable antitubercular drugs. Third group, fluoroquinolones. Fourth group, second-line oral antitubercular drugs. And fifth group, drugs with unclear efficacy. Group 1 are the most potent and best tolerated oral drugs used routinely. Group 2 are potent and bactericidal but injectable drugs. Group 3 includes fluoroquinolones, which are well-tolerated bactericidal oral drugs. All patients with drug-resistant tuberculosis should receive one fluoroquinolone. Group 4 are less effective, bacteriostatic, more toxic oral drugs for resistant tuberculosis. And Group 5 are drugs with uncertain efficacy. The next group is antileprotic drugs. Leprosy caused by Mycobacterium lepra. Classification of drugs. Holmugra oil, weak antileprotic property. Sulfone, dapsone. Phenazine derivative, clofazimine. Antitubercular drugs, rifampin, etionamide, and other antibiotics. Ofloxacin, moxifloxacin, minocycline, clarithromycin. Antiviral drugs are subdivided into anti-herpes virus, anti-influenza virus, anti-hepatitis virus, non-selective antiviral drugs, and antiretrovirus. Anti-herpes virus, edoxuridine, trifluridine, acyclovir, valacyclovir, famciclovir, ganciclovir, valganciclovir, cidofovir, foscarnet, fomivirsen. Anti-influenza virus, amantadine, rimantadine, oseltamivir, zanamivir. Anti-hepatitis virus, non-selective antiviral drugs, primary for hepatitis B, lamivudine, adefovir dipivoxil, tenofovir. And primary for hepatitis C, ribavirin, interferon alpha. Antiretrovirus antiviral drugs. First, nucleoside reverse transcriptase inhibitor, zidovudine, didanosine, stavudine, lamivudine, abacavir, emtricitabine, tenofovir. Next, non-nucleoside reverse transcriptase inhibitor, nevirapine, efavirenz, delavirdine. Next, protease inhibitors, ritonavir, atazanavir, indinavir, nelfinavir, saquinavir, amprenavir, lopinavir. Also, entry-fusion inhibitor, enfuvirtide. Also, hemokine coreceptor 5 inhibitor, maraviroc, and integrase inhibitor, raltegravir. The next group is antimalarial drugs. Antimalarial medications, also known as antimalarials, are designed to prevent or cure malaria. Such drugs may be useful for some or all of the following: treatment of malaria in individuals with suspected or confirmed infection, prevention of infection in individuals visiting a malaria endemic region who have no immunity, malaria prophylaxis, and routine intermittent treatment of certain groups in endemic regions, intermittent preventive therapy. Some antimalarial agents, particularly chloroquine and hydroxychloroquine, are also used in the treatment of rheumatoid arthritis and lupus-associated arthritis. Current practice in treating cases of malaria is based on the concept of combination therapy, since this offers several advantages, including reduced risk of treatment failure, reduced risk of developing resistance, enhanced convenience, and reduced side effects. Prompt parasitological confirmation by microscopy, or alternatively by rapid diagnostic tests, is recommended in all patients suspected of malaria before treatment is started. Treatment solely on the basis of clinical suspicion should only be considered when a parasitological diagnosis is not accessible. In here you can see the life cycle of malaria parasite in men, stages and forms of the parasite at which different types of antimalarial drugs are indicated. Antimalarial drugs classification: 4 aminoquinolones, quinolone methanol, cinchona alkaloid, biguanide, diaminopyrimidine, 8 aminoquinolone, sulfonamides and sulfone, antibiotics, sesquiterpene lactones, amino alcohols, naphthyridine, naphthoquinone. Objectives and use. The aims of using drugs in relation to malarial infection are to prevent clinical attack of malaria, prophylactic use, casual prophylaxis and suppressive prophylaxis, to treat clinical attack of malaria, clinical curative use, to completely eradicate the parasite from the patient's body, radical curative use, to cut down human-to-mosquito transmission, gametocidal use. The next one is anti-amebiasis infection. Amebiasis is present all over the world. About 480 million people are affected with what appears to be Entamoeba histolytica, and this results in the death of between 40,000 to 110,000 people every year. Most infections are now ascribed to Entamoeba dispar. Entamoeba dispar is more common in certain areas, and symptomatic cases may be fewer than previously reported. The first case of amebiasis was documented in 1875, and in 1891 the disease was described in detail, resulting in the terms amoebic dysentery and amoebic liver abscesses. Further evidence from the Philippines in 1913 found that upon ingesting sites of Entamoeba histolytica, volunteers developed the disease. It has been known since 1897 that at least one non-disease-causing species of Entamoeba existed, Entamoeba coli, but it was first formally recognized by the World Health Organization in 1997 that Entamoeba histolytica was two species, despite this having first been proposed in 1925. In addition to the now recognized Entamoeba dispar, evidence shows that there are at least two other species of Entamoeba that look the same in humans, Entamoeba moshkovsky and Entamoeba bangladeshi. The reason these species haven't been differentiated until recently is because of their reliance on appearance. Amebiasis, also known as amebiasis or entamebiasis, is an infection caused by any of the amebiases of the Entamoeba group. Symptoms are most common upon infection by Entamoeba histolytica. Amebiasis can present with no, mild, or severe symptoms. Symptoms may include abdominal pain, mild diarrhea, bloody diarrhea, or severe colitis with tissue death and perforation. This last complication may cause peritonitis. People affected may develop anemia due to loss of blood. Invasion of the intestinal lining causes amoebic bloody diarrhea or amoebic colitis. If the parasite reaches the bloodstream, it can spread through the body, most frequently ending up in the liver, where it causes amoebic liver abscesses. Liver abscesses can occur without previous diarrhea. Cysts of Entamoeba can survive for up to a month in soil or for up to 45 minutes under fingernails. It is important to differentiate between amebiasis and bacterial colitis. The preferred diagnostic method is through fecal examination under microscope, but requires a skilled microscopist and may not be reliable when excluding infection. This method, however, may not be able to separate between specific types. Increased white blood cell count is present in severe cases, but not in mild ones. The most accurate test is for antibodies in the blood, but it may remain positive following treatment. Antiamoebic drugs are drugs useful in amebiasis. For both intestinal and extraintestinal amebiasis, nitroimidazoles, alkaloids. For extraintestinal amebiasis, chloroquine, luminal amebicides, amide, 8-hydroxyquinolones, antibiotics. And in here you can see treatment of different forms of amebiotic infection. Anti-amebiasis prevention. Prevention of amebiasis is by separating food and water from feces and by proper sanitation measures. There is no vaccine. There are two treatment options depending on the location of the infection. Amebiasis in tissues is treated with either metronidazole, tinidazole, nitazoxanide, dihydroamidine, or chloroquine, while luminal infection is treated with diloxanide furoate or iodoquinoline. For treatment to be effective against all stages of the amoeba may require a combination of medications. Infections without symptoms do not require treatment, but infected individuals can spread the parasite to others and treatment can be considered. Treatment of other entamoeba infections, apart from entamoeba histolytica, is not needed. And the last group for today is antihelmintic drugs. Antihelmintics are a group of antiparasitic drugs that expel parasitic worms, helminths, and other internal parasites from the body by either stunning or killing them and without causing significant damage to the host. They may also be called vermifuges, those that stun, or vermicides, those that kill. They are used to treat people or animals who are infected by helminths, a condition called helminthiasis. Drugs containing antihelmintics are used in mass deworming campaigns of school-aged children in many developing countries. The treatment of choice for soil-transmitted helminths is mebendazole and albendazole and praziquantel. Forms of helminthiasis: roundworms, hookworm, pinworm, threadworms, whipworms, filaria, guinea worm, tapeworms, hydatid disease. And in here you can see choice of drugs for different types of helminthiasis. You can pause this slide and look through this picture. Some examples of drugs: first choice drugs, mebendazole, albendazole, praziquantel, and alternative drugs, piperazine, levomizole, pyrantel. And the last part of our lecture is examples of MCQs. A 19-year-old patient has primary syphilis. He gets a complex therapy. Benzylpenicillin sodium is a part of this therapy. What is the mechanism of this drug action? The correct answer is E. Blockade of microbe membrane peptidoglycan synthesis. In all other MCQs, the correct answer also will be E. A patient was admitted to the infection unit with diagnosis of bacterial dysentery. On laboratory examinations, it was revealed that causative element is sensitive to many antimicrobial medicines, but patient has anemia. What drug is contraindicated to the patient? In this case, it is levomycetin. A patient with pneumonia was treated with antibiotics for a long period. After treatment, patient complains of frequent and watery stool, abdominal pain. What is the reason of intestine function disorder? Of course, it is dysbacteriosis. Option E. Serious generalized septic infection menacing to life has developed in patient. What of the listed groups of chemotherapeutic agents should be used in this case? The answer is cephalosporins. Treatment course of bacterial pneumonia included benzylpenicillin sodium salt. What is the mechanism of its antimicrobial action? Of course, it is inhibition of cell wall synthesis of the microorganism. Gonorrhea was revealed in a patient on bacterioscopy of the smear from urethra. Taking into account that medicines from gonorrhea are fluoroquinolones, patients should be prescribed, of course, ciprofloxacin. A doctor prescribed sulfonamide to patient with pneumonia. What is the mechanism of sulfonamide's action? Competitive antagonism with para-aminobenzoic acid. A patient has appealed to the doctor with complaints of red color of urine and tears. It is known that he is treated for pulmonary tuberculosis. What drug can cause this adverse effect? Of course, it is rifampicin. Neuritis of optic nerve occurred in the patient in result of treating with certain antituberculosis drug. Identified this drug. Of course, it is isoniazid. A dentist diagnosed herpetic stomatitis. What is necessary to prescribe for treatment in this case? Of course, it is acyclovir. Systemic amoebiasis with involvement of intestines, liver, and lungs was diagnosed in a 52-year-old patient. What drug should be prescribed? Of course, metronidazole. Drug A is prescribed to a patient with ulcer disease of stomach. It is known that drug A suppresses the growth and reproduction of Helicobacter pylori. Indicate this drug. Of course, metronidazole. Thank you for the attention.